failed. However, patients greater than 35 years of age, they should perhaps wait only 6 months after attempted natural conception before fertility therapy referral is made. The success rates of artificial reproductive technology may be decreased in patients with IBD. This meta-analysis shows that patients with Crohn's disease surgery to be less likely to deliver live births per cycle of artificial reproductive technology compared to patients who had Crohn's disease medical therapy. Pregnancies per cycle of ART in Crohn's disease is probably normal, but live births per cycle of ART in Crohn's disease is significantly decreased. Ulcerative colitis, however, is normal when it comes to pregnancies as well as live births per cycle of ART. So fertility therapy is recommended for patients with unsuccessful natural conception, and this can include intracytoplasmic sperm injection, intrauterine insemination, and in vitro fertilization. Next phase of the clinical care pathway is the pregnancy itself. This involves a multidisciplinary care team combining gastroenterologist, obstetrician, maternal fetal medicine, and pediatrician. During this phase, the pregnancy is monitored, as well as monitoring of the IBD during pregnancy, monitoring of medications, and the nutrition and weight gain. This is a list of medications and how they should be used during pregnancy and lactation. The drugs with the green bar suggest that they are low risk and can continue to be used during pregnancy and lactation. Blue bars are where there are minimal data. The orange and red bars suggest that they should be avoided during pregnancy and or lactation. So the drugs that we need to avoid are methotrexate and tofacitinib during pregnancy and lactation, and cyclosporine during lactation. Here are 3 cohort studies from the USA and Sweden showing the use of medications during pregnancy in the past 2 decades. What you can see is that the use of mesalazine, immunomodulators, and systemic corticosteroids to have remained relatively stable in the past 2 decades. However, there's been an increasing use of anti-TNFs during pregnancy as our attitude towards this class of drug changed over time. So 8 to 15% of patients undergoing pregnancy with IBD are now on anti-TNF agents. And guidelines suggest that anti-TNF agents can be continued because cessation of their therapy is associated with increasing risk of flares as well as poorer outcomes in the infants. Biological agents that have the IgG1 structure are actively transported across the placenta during pregnancy. Certolizumab is the only exception where the PEG fragment stops transfer of the drug across the placenta. Infliximab, adalimumab, and ustekinumab are all concentrated in the infants with high concentration in infant versus the mother. Vedolizumab is also transported across the placenta but has a lower concentration in the fetus than in the mother. Because the biological agents are transferred across the placenta during pregnancy, it's been recommended for those patients that are in remission, the last dose of the biological agent can be timed between 30 to 36 weeks of gestation. And that way it will minimize the excessive amounts of IgG1 agent to be crossing the placenta. That's only for patients in remission. For those that have active disease, they should continue throughout the pregnancy because withdrawal of biological agent can precipitate a clinical flare. These are cohorts of patients on vedolizumab compared against those that are on anti-TNFs and on biological agents. And what it shows is that the numbers of patients with live births, miscarriages, and congenital anomaly to be no different to that of the general population. So it suggests there is no difference in miscarriages, the APGAR scores on delivery, the prematurity rates, live births, gestational age, and birth weights comparing patients on vedolizumab versus anti-TNFs versus non-biological agents. So this is Emma Flanagan's study from Australia with the first 5 patients on vedolizumab, and it shows that the infant's maternal ratio to be less than 1, suggesting that the has a lower level of the drug compared to the mother. And the drug is cleared relatively rapidly in the infants as well, so by 16 weeks all the drug seems to have disappeared. There was 1 case out of the 5 with hip dysplasia. Extension of this study has now been published, and it shows consistently that vedolizumab levels in infants to be quite low and to have disappeared by 10 to 15 weeks after delivery. So in all, the biological clearance is roughly at average 7.3 months for infliximab, 4.0 months for adalimumab, and 2.5 months for vedolizumab, indicating vedolizumab has a more rapid clearance than anti-TNF agents in the fetus. For ustekinumab, this has been assessed using a global safety database up to 30th of June 2017, where patients have been exposed to ustekinumab approximately 2 months pre-conception all the way up to pregnancy. So there's also a known reported pregnancy outcome. As such, only 206 out of 727 subjects have been analysed, mostly from subjects that had psoriasis, and 36 patients had Crohn's disease. Some of these were prospective and some of these were retrospective data, but the average maternal age was 30 years. So these are the time periods of patients' exposure with ustekinumab during the pregnancy or before, prior to conception, and it shows that there were no cases with genital anomalies. So comparing this against general population in the USA, it shows that overall live birth without congenital anomaly to be roughly similar between subjects that have been exposed to ustekinumab versus the general population. Likewise, the live births with congenital anomaly was 4.4% in ustekinumab treated patients and 4.0% in the general population, suggesting that there is no specific risk being identified in those that had ustekinumab exposure during pregnancy. Tofacitinib has feticidal and teratogenic properties in animals exposed to extremely high levels, some 73-fold greater than that of the dosage exposed in humans. In a cohort of 158 cases of maternal or paternal exposure of tofacitinib, the majority of pregnancy resulted in healthy children, 96 healthy deliveries compared to 1 pulmonary valve stenosis. In IBD-specific cohorts of 11 maternal exposure and 14 paternal exposure, there were no congenital anomalies, no fetal or neonatal deaths. However, due to lack of data, tofacitinib is not recommended for use in IBD cohorts during pregnancy. In terms of delivery, prior rectal vaginal fistulas and the presence of perineal disease suggest that the mother should deliver by cesarean section. In the absence of perineal disease, then the decision is made by the obstetrician whether this should be a vaginal or cesarean delivery. For patients with a J pouch, then consideration for cesarean section must be made. Vaginal delivery does not cause flares or increase the risk of perianal Crohn's disease. Wound healing is not influenced by the disease, but wound infection rates may be increased in patients exposed to corticosteroids during pregnancy. IBD does not influence the method of delivery, therefore it's up to the patient and obstetrician, with the proviso, as stated before, that perineal disease and rectal vaginal fistulas to be delivered with cesarean section, and patients with a J pouch for consideration of cesarean section to reduce trauma to the sphincter and decrease risk of incontinence later. Venous thromboembolism is increased in IBD patients during pregnancy by 2.13-fold and postpartum by 2.61-fold. Seems like the risk is mostly with deep venous thrombosis and not with pulmonary embolism. So postpartum issues relate to lactation and breastfeeding. This is a systematic review and meta-analysis demonstrating breastfeeding to decrease the risk of both Crohn's disease and ulcerative colitis. And there was a duration response effect where the greater the duration of breastfeeding, lower is the risk of the infant in developing inflammatory bowel diseases. So this is a recommendation that one should breastfeed for at least 12 months because this is associated with a decrease of the risk of developing IBD by 80%. So with breastfeeding, one needs to avoid the use of methotrexate, tofacitinib, and cyclosporin, but 5-ASAs, thiopurines, and biological agents are considered to be safe. So babies with anti-TNF in pregnancy, they may have detectable levels until 12 months of age. However, this is not associated with any developmental delay, but one needs to avoid live vaccines during this time. One also needs to avoid traveling to TB endemic countries with the baby as well because of the higher levels of anti-TNF agent in the infants, even compared to the mother. So we all remember there was a case report of disseminated BCG infection in an infant born to a mother who was exposed to anti-TNFs during pregnancy. So this is a schedule of vaccinations in Australia, and it shows that the live vaccinations to be rotavirus at 2 months and 4 months after birth, and the other vaccinations are non-live. So the biological agents tend to have cleared by 12 months, so the MMR vaccination at 12 months tends to be quite safe. Immunisation schedules differ around the world. In India, there are 3 time periods where live vaccines may be given, and they include the BCG vaccine given as early as possible, rotavirus vaccine at 6, 10, and 14 weeks, and Japanese encephalitis given at 9 to 12 months. This is a study of 90 pregnancies where the mothers had IBD on anti-TNF agents, and the infant that was born after exposure to anti-TNF in utero received the BCG vaccination. When the anti-TNF exposure was prior to the 3rd trimester, there was a low risk of adverse outcomes. With the BCG given at 1 month after delivery, there was a risk of axillary lymphadenopathy of 4.5%. However, if the BCG was given after 6 months, there were no adverse outcomes. Of mothers that received anti-TNF agents during the 3rd trimester, there was complications when BCG was given after 1 month, between 1 and 6 months of delivery, with axillary lymphadenopathy and swelling of the injection site. However, if BCG was given after 6 months, there was no adverse outcomes. Importantly, there were no deaths or systemic dissemination of BCG. COVID-19 mRNA vaccinations are safe during pregnancy, and in fact, recommendation is to give the vaccination at any stage during pregnancy to help passive transfer of immunoglobulins to protect the newborn after delivery. In terms of responsiveness of the vaccinations themselves with prior exposure to biological agents, it seems to be similar between those that had exposure to biological agents versus babies that had no exposure to biological agents. So the efficacy of vaccination response rates are the same. So there was also very little complications associated with vaccinations, as can be seen on this table. So how does one manage flares during pregnancy? Well, the management seems to be similar whether you are pregnant versus not pregnant. So it depends also how close you are to delivery, the decision to use steroids versus infliximab. One should not start thiopurine during pregnancy with the risk of development of pancreatitis as well as the slow onset of the drug. One should also avoid 5-ASA dose increase because this is often inadequate and takes time. Also, one needs to follow up closely, probably using fecal calprotectins as well as sigmoidoscopy, but one should avoid colonoscopy because of the invasiveness of the procedure. Corticosteroids is considered to be safe by both the HEA and ECHO guidelines. It does cross the placenta, but is not activated in the budesonide may be riskier because of the powerful effects of the drug. One also has possible concerns about congenital anomalies, but this was done in the setting of severe disease, and it might be a confounding factor rather than corticosteroids causing congenital anomalies themselves. So what about for the treatment of acute severe ulcerative colitis? Well, our evidence-based guidelines published in PT 2016 says in statement 29 that the management of acute severe ulcerative colitis in pregnancy does not change. One can use corticosteroids, cyclosporin, thiopurines, infliximab, and colectomy as needed in all stages of pregnancy. So in conclusion, one divides the pregnancy into 4 phases of preconception, early pregnancy, late pregnancy, and postpartum. And you can see each of the factors associated with these phases listed here. You can also look at the IBD Parenthood Project.gastro.org for these clinical care pathways, and includes the guidelines associated with the pathways as well. So it just remains for me to thank you, Rupert, for inviting me to present at the IBD Masterclass, and I do look forward to meeting up with you very soon. Thank you very much for your attention.
Thank you, Rupert, for the excellent talk as usual. We go on to the next talk for the evening, and this is a very important area which we never address, and that is why it is very relevant in today's world. So this is regarding the sexual health related challenges for the young IBD patients that we are seeing today. And to give this talk is none other than my dear friend, Professor Jane Andrews. Professor Jane Andrews, Jane has been working in this area for a long time, has numerous publications related to sexuality, fertility, and IBD in pregnancy. Jane is the head of IBD service and education at the Department of Gastroenterology and Hepatology at the Royal Adelaide Hospital in Australia, and is also the clinical professor at the School of Medicine, University of Adelaide. Thank you so much, Jane, and over to you for the interesting talk which I suppose everyone will enjoy, will need in their clinical.
Okay, so thank you very much for inviting me to come and speak with you about navigating sex and sexual health in inflammatory bowel disease. I'd like to point out that although this topic was meant to be for the young patients, I think it's really important that we acknowledge that navigating sex and sexual health is not just important for the young. And I'd like to very much thank my colleague and friend, Professor Rupert Banerjee, for inviting me to speak with you virtually from my home here in Adelaide into your homes and your workplaces. So thank you. So in terms of navigating sex in IBD, there are some really important things. Firstly, I need to show you my disclosures, and the point of that is to show that I'm prepared to take funding from anyone who's prepared to support research. So back to our topic at hand. The things that I'd like to run you through are really quite strategic, thinking about disease control in IBD, thinking about medications, potential side effects, both real side effects and also perceived side effects, because they can be just as important. Body image is really important, and again, we will see later that perception is very important, particularly surgery, scars, weight, stomas, and extraintestinal manifestations may influence people's body image. Symptoms are also really important, and I'll show you some interesting data about the difference in symptoms between irritable bowel syndrome and inflammatory bowel disease as it pertains to aspects related to sexual function and sexual health. Expectations are also really important, because most sexuality is actually experienced in our minds rather than in our sexual organs. And people's mindset and their expectations is really central to how people experience sex. Mental health is also important, and I think that most people know this intuitively. And finally, but perhaps not finally, perhaps actually we should put this at the top, accurate information is just vital. And that's where you, as doctors looking after people with IBD, are really vital, because if you have accurate information, you can share it with your patients, and that's really important. The other thing I'd like to mention is that all of this discussion about navigating sexual health and sexual function in IBD is really not so different to all of us, whether we have IBD or not. Sex and body image, it's often a taboo area. Many people are afraid to ask and suffer in isolation. So there was a very nice review published earlier this year in the Internal Journal of General Medicine, and it looked at sexual dysfunction in IBD, and it divided things up into the factors which were involved in the development of sexual dysfunction, or we could frame it more positively, the factors that are important to address so that we have no dysfunction. So there are biological factors, there are IBD factors, drugs, surgery, psychological factors, and social factors. And what I liked was I found this slide after I had made my previous slide, and it shows you that really those kind of concepts hold true regardless of who you are and where you're thinking about this from. So there are some areas that are really not IBD specific. So biological factors such as just sexual dysfunction is more likely if you are older. Sexual dysfunction is more commonly reported in women than in men, and also more common in people who have other medical conditions, for example, diabetes and hypogonadism. If we go down to psychological factors, you don't have to have IBD for anxiety or depression to impair your sexual health. And the other thing is social factors. These are not unique to IBD. We all have our own social factors. There can be factors around prior sexual experiences, both pleasant and unpleasant, and also social and cultural contexts around sexual function and expectations of sexual function. There are then, with these green arrows, some very IBD specific areas that we need to concentrate on as IBD doctors. And they are, the fact that there is more sexual dysfunction in Crohn's than in UC. Active perianal Crohn's disease is clearly a very obvious factor that is going to impair sexual health. Disease activity, likewise, it's not surprising. And duration of disease in some people actually correlates with better sexual health rather than worse sexual health. And perhaps that's because people get acclimatized and they and their partner find a way of dealing with their sexual activity which is not interfered with by their diagnosis. Drugs for IBD are very important as well, and particularly corticosteroid drugs are important, and that's because they change various aspects of body image, particularly with weight gain and mood disturbance. Other drugs are not so important, but psychotropic drugs and opioids can also impair sexual function. Surgical factors are also very important and are IBD specific. Now, they're not relevant to all our patients, but they are relevant to small subsets of patients. And in those patients, they're very important to address. So let's go through some of these areas in a little bit more detail, one at a time. First of all, I thought we'd start with something obvious because we're IBD doctors and we want to control the IBD. Let's look at the importance of disease control. It seems very obvious, but it is often neglected. I think a couple of patient stories came to me that really exemplified the importance and the relevance of disease control. I met a young woman with fistulizing perianal disease who was otherwise very well. She told me during our first consultation that she was really not bothered about her perianal disease. She didn't see the need to start a biologic medication despite this very nasty fistulizing disease. And she said it wasn't interfering with her life whatsoever. We did actually get past that. I pointed out that we were not just about controlling symptoms, but we were intending to prevent worse complications and perhaps a stoma. And she was persuaded to start her anti-TNF therapy. At her next visit, she reported that she was pregnant. And it was really interesting in that discussion because she said, oh, well, I wasn't using any contraception because I wasn't sexually active before. And because she went on the anti-TNF therapy and it healed her fistulizing disease, she then resumed sexual activity. So this was an example to me of where I had missed an important part of the history. This was a young woman who had a partner, had one child, had planned for other children, but was clearly not sexually active and herself had even discounted that as a symptom. So that's something to just always bear in mind, is fistulizing disease, is perianal disease interfering or preventing sexual activity in people who would otherwise be active? It's an important part of their quality of life. Another young woman who I met many years ago now when we first had anti-TNF drugs coming into our clinic, she had very nasty perianal cutaneous Crohn's disease. She'd been married for almost 2 years when I met her, and she and her husband had not yet been able to consummate their marriage because of her very severe perianal cutaneous disease. They both gave me great hugs after the anti-TNF therapy was started because they felt that their marriage had really just started. So again, it brought back to me that this was actually such an easy thing to fix, but we hadn't even really perceived that it was a problem for those patients until after we fixed the issue, because we were treating the disease. However, we were also facilitating them returning to a normal life for someone who was young and partnered. And so I think that we need to think about, is the disease really as well controlled as we assume? Because when people sit there in your office with their clothes on, we're not seeing them as sexual beings. But that's a very important part of who most people are. And people are never going to have a family if they're not able to have their sexual relations. And their marriages may not survive either. And that would be a tragedy. So they were two young women for whom disease control was really, really important. It's interesting because sometimes disease control doesn't prevent people from having a sexual relationship. So people with active luminal disease, if their relationship is otherwise good, there's less interference than we might imagine. And I'd like to emphasise that with modern IBD management, this should be less and less of a problem, because we should all be aiming for good disease control all the time. And so when there is active disease, it should only temporarily interfere with people's quality of life, including their sexual health. We all obviously do want to avoid malnutrition and excess weight loss. And if sexual dysfunction doesn't resolve with remission, remember to check back in and to see if there are other issues for that particular patient. So leaving disease control to one side, let's move on specifically to look at the effect of medications on sexual health. I think it's really important that we always check on adherence with people's medications and check whether they perceive that taking medication X or medication Y is a problem for them, or whether they feel there's a barrier. Particularly steroids, as I mentioned earlier, will create mood disturbance in many people, and so always anticipate that and warn people about that. Weight gain, particularly if one uses steroids for more than a couple of weeks, is also pretty predictable. And whilst if someone was very underweight, a little bit of weight gain can be good, most women are not going to feel very sexy if they're gaining weight and feeling bloated and feeling bulky. Thiopurines are often associated with a lot of fear, and that's fear of an abnormal pregnancy or an abnormal pregnancy outcome. And so it's good to get in early and to address that fear with your patients and to be very explicit about the really great safety data for thiopurines for pregnancy, conception and childbirth, and even for breastfeeding. Thiopurines are not a drug of concern to us, but that doesn't mean that our patients know that if we don't address it with them directly. I'm always very concerned about people who are on opiate medications, because to me that's a marker for problems with pain, problems with mental health, and problems with uncontrolled or incompletely controlled IBD disease activity. So if people are needing opiates, then I think that we need to look harder and look more carefully for what we can do to optimise their quality of life. And I'd like to emphasise that with all of our modern biologic agents, there are particularly no real issues with sexual function and sexual health, and very, very few issues with pregnancy, fertility, childbearing and breastfeeding. We were very worried about them, going back a decade or more, but now there is really a lot of data, particularly for the anti-TNF drugs and the vedolizumab, and increasing evidence also for Stelara, that they are, although not recommended or not licensed specifically for use in pregnancy, we are not seeing problems in post-marketing surveillance data. And that's really important, because real-world data is where we get the real safety data with drugs. So in summary there, I think the medications really tie into active disease, systemic wellbeing and mental health management. So it's good to address them specifically. Just a little bit more about adherence and perceptions. Going back now over a decade, Kate Muller, who was a registrar training with me some years back, did a little survey, and what we found was that 10% of patients with IBD omitted their medications because they felt their medications decreased their libido or impaired their body image or did something which was going to give them what they perceived as sexual dysfunction. Now, this was a really interesting finding to us because it wasn't something that we had anticipated, and so we didn't have a lot of very detailed qualitative data as to why they felt these drugs were going to impair their sexual function. But that's a really important thing, that 1 in 10 patients may be not taking their medications as you think they are because they're worried about it impairing their sexual function. So it's a good thing to ask about, particularly in younger patients. We also know from work that was published by Rami Mounterfield, who was a PhD student of mine a little later, that covert dose reduction is really common in people with IBD. So you might ask, are you taking your medications? And they'll say, yes, but they mightn't be taking exactly what you think they're taking in the dose that they're taking it. So they're very important things to explore before you have a flare, because we know a flare is going to be bad for the patient in more ways than just creating sexual dysfunction. So turning now to body image, this is a really, really important part of sexual health, because if people don't feel good about themselves, they're not really going to be wanting to be vulnerable and to be engaged in sexual activity. Body image is really important for patients, reportedly more commonly impaired in women than in men, and in IBD patients, that's no different. These are more data from our big survey on patient perceptions of sexuality, body image, and libido, published by Kate Muller in 2009. She found that more people reported disturbance of their body image if they'd had a surgery, as opposed to people who had not had a surgery. More women than men reported impaired body image. Stomas universally impaired people's body image. But the interesting thing was, so did limited resections. So people who only had a little bikini cut scar, as if they'd had an appendectomy, also reported problems with body image, which was very interesting to us again. Again, we found that in this survey, opiates and steroids were a problem. But again, hopefully, with modern IBD management, these are a disappearing issue. They create more problems than they're worth in most people. So it was interesting again with body image. We looked at laparoscopic versus open surgery, and there was really no difference in how much the body image was perceived to be impaired by the patient. People who had a pouch, so they had intestinal continuity, they had better sexual function, which was self-reported, than with people who had an end stoma. But there was no difference when we compared the type of pouch from stapled or hand sewn. So these sort of surgical technical differences that our surgeons often talk about a lot, in the long run, once people got a result, they didn't create any difference for patients in terms of body image. The interesting thing is, just because these things tend to create statistically sexual dysfunction, it doesn't mean that every patient who has surgery or every patient who has a stoma has sexual dysfunction all the time. We also tried to look at extraintestinal manifestations, and these may affect sexual dysfunction. However, there's almost no good quality data that we have or that other groups have on the influence of extraintestinal manifestations. But I think, if you've got sore joints, if you've got nasty erythema nodosum, if you've got pyoderma, if you've got a lot of mouth ulcers, it makes perfect sense, particularly when they co-associate with active disease, that you're not going to feel really, in the mood for being intimate. So they're worth managing. Let's turn now to symptoms. Now, symptoms in gastroenterology are really, really interesting, because those of you who've been in practice for some time will know that symptoms and lesions don't match very well. Otherwise, we wouldn't be able to have a disease with lots of symptoms and no lesions, which is irritable bowel syndrome. And then we all know that we have patients who have lots of lesions, including advanced cancers, who present with very few symptoms. So this concept is really important. We know that IBS is very common in people with IBD, and we know that the symptoms are very similar. So just because people have symptoms doesn't mean they have active IBD, and that's important because the treatment, if it's IBS symptoms, is going to be very different from the treatment if people have IBD symptoms. Now, some years ago, we had a PhD student, Katie Croker, who unfortunately didn't finish her degree and didn't publish much of her work beyond abstract form. But she did a survey that matched the survey we had done in our IBD cohort. So this is the data in these 365 IBD patients that I was showing you earlier, compared with 252 patients with functional bowel disorders. And what we found was that 36% of the functional group and 64% of the IBD group reported decreased level of sexual activity after their disease onset. So 1/3 of the functional group and 2/3 of the IBD group. However, we didn't find any significant differences between the functional group and the IBD group for specific question areas, such as whether they had a long-term sexual partner or not, whether they felt their body image was currently impaired, whether they felt their libido was currently impaired, or whether their current frequency of sexual activity was different to what they thought was normal. So that was really interesting that they weren't impaired differentially at that point in time. It's also interesting when we asked about common symptoms and common concerns. This is the functional group here in the column closest to the descriptors, and this is the IBD group over here towards the right-hand side of the slide. People reported that their general feeling of being tired or unwell, impairing sexual activity, was much more common in the functional group than the IBD group. Still high in both groups, but interestingly more common where there's no visible disease, but just lots of symptoms. It was interesting that when we asked why people felt that their sexual function was impaired, the functional group were much more likely to put it down to difficult to control symptoms and abdominal bloating than the IBD group, who really didn't find that they were impaired by difficult to control symptoms or bloating. So that's really interesting. People with more organic, more obvious, more visible disease with tissue damage are having less trouble in this aspect. Disease flares and medication side effects were more of an issue for the IBD patients, as were surgical issues, and the IBD patients were more often likely to report that these issues resolved during remission than the people with functional bowel disease, who really reported that their symptoms were with them most of the time. So that's really interesting. Our data, which were a large data set, showed that people with IBD were perhaps less impaired with respect to sexual function than those with functional disease. Their qualitative concerns varied, and the IBD issues were more responsive to things which we think of as IBD specific, such as medications, disease activity, and surgery. So those themes continue to come through. So let's look now at expectations, and these are important. And there's more than one set of expectations to address. There's the patient's expectations, so they're very important. There are also our expectations as doctors, and sometimes when it comes to sexual function in IBD, we haven't even got any expectations because we might be just thinking that our job is to manage the IBD. But I put it to you that our job is actually to find out what's also going on in other hidden areas for the patients, because sometimes we can fix those things very easily, and sometimes it's only through a quick discussion. We also need to look at their partner's expectations, because sometimes partners will have thoughts and concerns and worries that they won't bring up either, and sometimes they're also very easy to address. What I've found over the nearly 30 years that I've been working in IBD is that people, patients, doctors and partners, can all be too willing to accept role limitation due to IBD. And I think that the one thing I've learned over the last decade or more is that we should have heightened expectations, not only of normal quantity of life in IBD, but normal quality of life, which is achievable for most of our patients if we treat logically and proactively and have the right discussions. So I think this whole raising expectations is absolutely vital, and I would exhort you all to not settle for near enough is good enough in IBD, because mostly it's not, and mostly we can achieve more. And, let's be also non-naive and just, open and honest that even people without IBD have sexual issues. So we're not going to think just because you've got IBD that you won't have any sexual issues, and we're not also going to think that they have to be due to your IBD. Because when we allow the IBD to be unfairly blamed for a problem, we prevent ourselves from getting a chance to solve the real problem. And we might be proposing the wrong solution. And again, this can create its own issues. That brings us into mental health. And this, beforehand, has really been a neglected area of all chronic disease management. Maybe because we haven't felt that it's within our skill set to manage, maybe because we've been too busy managing the active disease, maybe we just don't feel that it's our responsibility. But I think now there is so much data that this is important in IBD and that we get better outcomes when we do it well, that we shouldn't neglect it any longer. In fact, my first PhD student, Antonina Makoko-Wallace, who's gone on to become, a powerhouse of psychological expertise in IBD internationally, has published this review in the IBD Journal now back 5 years ago, presenting that anxiety and depression in a meta-analysis are present in 19 and 21% of people with IBD. I think that based on newer data from a newer PhD student who's being co-supervised by Antonina and myself, that this is probably an underestimate. When we do proactive screening in our patients with IBD in routine care, we find that 1 in 5, so 20% of patients, need and accept mental health care. So a much larger number actually screen positive, but then don't accept the care. I think it's more likely 30-something, maybe even approaching 40% of people have relevant mental health issues that we should at least be finding. We also know that depression, especially, is a consistent predictor of sexual dysfunction. Doesn't matter whether you have IBD or not. Anyone with relevant depression is not really going to have sexual function and sexual health that is where it needs to be for them to have great quality of life. Managing mental health issues in IBD yields broad gains. We know that it will improve your IBD management. We know it will decrease your healthcare utilisation. We know it will allow you to more completely participate in all of your roles in life, not just make your IBD better, but it will put you back into employment. It will make you a better parent. It will make you a better child. It will make you a better spouse. People with mental health issues are not able to participate in life fully. And so I would propose actually that screening for mental health issues is justified, because we don't have to be the doctors who treat it, but if we don't even ask about it, there's no opportunity for that patient to be recommended the right treatment. This is a suggested approach from the journal article I showed you earlier in the talk. And, they have their screening and multidisciplinary management of sexual dysfunction approach. This is probably an approach which is not really affordable in most IBD treatment settings because it's quite expensive and quite intensive. And they're assuming that you're going to have a sexual dysfunction specialist, you're going to have psychiatry and psychology, and you're going to have an IBD nurse. Now, not everybody is going to have all of those aspects, but I would say that it's very easy to use validated quality of life scales and very simple screening tools for depression and anxiety. And these can be self-scored. They can be very easily administered. And then if we use these scores when we initially diagnose someone with IBD and we apply active listening and allow long enough for our initial interview, and it doesn't have to be the specialist doctor. It can be, a less qualified doctor. It can be a junior staff member. It can be a medical student. It can be a nursing student. Lots of people can do the active listening off a script and just elicit all the questions. We need to think about disease activity, and when disease activity is bad, again, it's another good time to think about looking at mental health and quality of life screening. And then when we're thinking about, is our patient heading towards surgery, that's another really good time to think about inquiry around mental health and quality of life. Because to me, a lot of the sexual dysfunction that I've seen has been around diagnosis, disease activity and medications, and surgery. And if we think about mental health and sexual function in these areas and at these time points, we're going to give our patients the opportunity to have that picked up early and dealt with well. So, in summary, and thank you very much for your attention, I think that one of the things we really need to do is be prepared to provide accurate information. We need to be able to address these issues early. We need to be not embarrassed. If we're embarrassed, how do we start the discussion with our patients? Use transition care. So when someone is coming across at 16 or 18 years of age from the paediatric service, use that as an opportunity to say, look, you might not want to talk about this now. However, having children, being in a sexual relationship, being married, that's going to be something that we need to talk about because we don't want you having the wrong ideas. And I think that it's really good to explore these relationship issues and sexual function issues when the patient is well, so that you've planted the seed that you're a person they can come back to, or this is a relevant issue, not waiting until it's 5 minutes to midnight and they're going to have a stoma and they're worried about never having a child and their partner's worried about never having sex again and should they get divorced. I mean, there's all sorts of terrible things that go through people's minds if we leave it until there's an emergency situation. Most patients with good control are going to have just great sexual health and you're not going to need to address it. If they also have good mental health, that again is very protective against sexual dysfunction. Sometimes this discussion is only going to come up when discussing fertility. For some patients and some societies, it's a bit of a taboo still to talk about sexual dysfunction unless you're talking about it in the situation where you're talking about childbearing. But if that's where you need to cite your discussion, cite it there. Make it easy, make it approachable for people. And do ensure that there is a little bit of time or an opportunity that the patient can talk to you or another trusted person on their own. Because sometimes if mum or mother-in-law or partner or spouse, fiance is there, sometimes it won't come up. And you need to just have that little bit of a window of opportunity and even to give a leaflet and say, look, you might want to think about this. Here's an email address, or set up another meeting with the nurse, or give us a call if you want to talk further about this. So I don't think that IBD clinicians need to become sex therapists. That's not our job. But we also don't need to leave our patients wondering and suffering because they have a fear to ask. And I think, forget all the rest of it. If you just remember these two things, don't be afraid. You don't have to be the expert. You don't have to be a sex therapist. But don't let people sit there afraid to ask because you're not prepared to ask and talk about it. This is some suggested reading, and this can be available. I'm sure Rupert can share this with you if you're interested in pursuing it further. And I'd just like to wish you all well and hope that your communities are not suffering too much with this ongoing pandemic. Thank you.
Coverage on the sexual health related challenges in young IBD patients. We now move on to the next important session, and that is a panel discussion on issues beyond number of motions and bloody stool. And to moderate this session, we have our own Dr. S.K. Tyagi, a senior consultant gastroenterologist at Meerut, India. Apart from his major contributions in academics in the field of hepatitis C virus infection and with several publications in national and international journals, he's a versatile speaker and is an active participant in various debates at the annual GI conferences. Over to Dr. Tyagi to take us through the session. Over to you, sir.
Thank you, Dr. Jayanti. Thank you very much. I think the previous two lectures actually emphasized the fact of the importance of the panel discussion that we are going to have because they all actually led us to believe and to rightly believe that IBD is not just about the number of stools and the amount of blood that the patient is passing, and there's far more to it than just this. After all, what we are talking about today, that's the pregnancy. It is at the peak of the reproductive age that this disease also attains a peak. And most studies actually exclude pregnant women and lactating women from formal studies, and therefore the data continues to be limited, and therefore the communication tends to be limited, and the patient information about this problem tends to be limited. And almost 25%, this is the worldwide data, will have their first child after they've been diagnosed as IBD. It's a different matter whether this is a planned pregnancy as elsewhere or as an unplanned pregnancy, which is most of the time in our own country. The disease, therefore, as we had discussion in the previous two talks, needs a multidisciplinary approach. And therefore, I think it's absolutely fantastic that we have a panel which is multidisciplinary. We have Ida Hilma, who's a professor, Department of Medicine and head of gastroenterology at Kuala Lumpur in Malaysia. And don't go by her appearance, but she actually, if she wasn't a doctor, she would have wanted to be an actress. And therefore, I'm just trying to put forward that, there's more to it behind the disease, and there's more to it behind the faces which come out onto panel as experts and as professions and as somebody who is just stuck into books and illnesses. No, that's not the case. My second panelist, and when I name you, please raise your hand so that people know who you are. So, Ida, please raise your hand so we know we're talking about you. Next panelist that I have is Munira Jassan. She is a senior gastroenterologist and hepatologist at the Hamad Medical College at Doha in Qatar, and is an assistant professor Weill Cornell Medical College at Qatar. She is very sure that if she was not a gastroenterologist, she would be a gastronomic, because whenever she retires, which is a long way to go, she intends to have her own cuisine and a restaurant, and she is so focused, and you'll realize that from her answers as well. She has a name to it, and the name is all spices but no spice. So that is Ilma. Shobna Bhatia, yes, that's her. She is a former professor and head of gastroenterology at Seth GS Medical College and at KEM, and is currently at Sir H.N. Reliance Institute, and at the moment she is doing a lot of Gita reading because she wants to be at peace simultaneously along with all that's going on, and her bucket list is full of travel. I would not embarrass her by asking as to what would be the most exotic country that she would want to visit, because she's living in an extremely exotic country as it is. We have Professor Jayanti. She's as I told you, a very, very distinguished and a very multifaceted panelist. We have is Dr. Jayanti. She's a gynecologist, obstetrician, very famous. I was told that if you want an appointment with her, you got to take it for your second child. She's too busy for the first one, No, that's not true. I was just kidding. She is at JJ Hospital, sharing work with a husband who's a urologist. And she's so good at her hands that her passion is learning piano. So you see, I have these panelists, and then we have what was the missing link, the pediatrician. We have Dr. Surinder Yacha, who is a director and head of Professor Gastroenterology, liver transplant at the Sakara World Hospital in Bangalore, and at present, whenever he is either stressed, alone, not necessarily in the washrooms, he loves music, to sing, to listen. And when he feels lonely, he hears all those TV debates which could drive him as crazy as his own work would. So having all these wonderful people with me, I'll quickly get down to the business of discussing what we are here about. So let me ask you, Ida, as to I presume the first question that some of the youngsters would ask is the preconception issue, and would be, and it's to all the panelists, should I get married? They know they have the disease, they have suffered from it, and they would ask, should I get married? But to make the question a little more difficult, the answer changes by the person's being a male or a female. So if it were a male, what would be the concerns of this person asking you whether he should get married? And how would you address those? Honestly tell him what are the pitfalls in him taking the next step, or there are no pitfalls at all.
So, okay, that's a very, I guess what I want to ask is whether or not you think that a lot of people have asked me this, first of all, and actually nobody has ever asked me that, So I think that what I think is very interesting is that in Asians at least, and that's why I think we probably do need some data in Asia as well, being married, having children it's just, I would say practically, a very, very high percentage of people would want to do it, and I think, I mean, it's not something, and I think Jane Andrews talked about this, that we probably don't actively ask them, but I think a lot of them just assume that they should get married. But let's say somebody asks me this and says, should I get married? Of course, the answer I would say is definitely yes, if you want to. Because if, when, and then I would say if they ask me why, if they were to then say, should I get married? And then I would ask them, why would you be worried about whether or not you should get married? And then I would have to work after that based on what they tell me. And I think one of the biggest concerns, both in male and female, for sure, are the issues of their children, about their spouse, of their offspring having inflammatory bowel disease as well. I think this is one of the biggest ones that I find, and in fact, we just published some patient information leaflets in 2 languages, and that was in Malay and English, and we actually wanted to address this specifically, and that we said the chances of your child having inflammatory bowel disease is very, very low. I think to me that would be the main thing. That would be my concern.
Even before that, their first concern would be, marriage and procreation go side by side, at least in our culture. And therefore, once you're getting married, you're expected to be bearing children. So what would be the concerns of this young man? Or what would you advise him? That yes, you can get married, but you would be off something, or you should, take care of this. That's what I think the first question would be, is would it affect my sexual life? We've heard it, but we'd like to reinforce it by your answer.
Well, I think as long as you take your medications, as long as your disease is well controlled, then I think it shouldn't affect your sexual life. Or at least we should hope that it shouldn't affect it significantly. That would be my answer. And I have had young patients who are, who are diagnosed with inflammatory bowel disease. Well, I'm sure we all have, when they're 17, 18, sometimes even younger. And sometimes it's not them, but also their parents. And I usually do tell them, even if I give you biologic therapy and all these therapies, you're going to be able to get married, you're going to be able to have children, as long as we can control this disease, you'll be able to have a career that you want. So I think that's what I would tell him.
Dr. Munira, the same person asks you and is in active disease. So what would be your answers? As I had written to everybody, the second variable is the disease activity. First is the gender, in which we would probably have to see the person's gender and what are their concerns. But the second one actually is whether the person is in active disease, mild or severe, or is in remission. Would that would your answer change, or would you modify your answer to that person, asking him about this?
Well, thank you very much for inviting me for this wonderful gathering. Actually, it is big yes for any marriage. We shouldn't say no for that, whether it is arranged or whether it is a product of love story. We shouldn't say no, but we need to know the key word of that. For patients of IBD, whether a man or a lady, the counseling, it has to come with a good outcome for understanding for both parents, for the parents, for the partners, for the consequences of the disease, whether it is in remission or an acute or active or chronic activity. And I believe any secret of this, successful marriage, has to be of the understanding of both partners. And of course, the answer will be difficult for me, whether it is an active disease, whether I don't want the bride or the groom to run out from the festival looking for bathroom or something like that. We don't want them to disappear from their happiness. But yes, they need to be, I'd rather for me, myself, to be patients, to be in remission, to enjoy all the festivals and the preparations and all beloved guests for their events.
We had also heard from Professor Leong that being in remission actually improves the fertility and the chances of conception, and therefore perhaps you said that. But the question is, Shobna, how do you assess remission in, say, a young girl, or in a pregnant lady, or somebody who's already pregnant? Because the next questions would be the management during pregnancy, in remission as well as in disease. But what are the options you would have, and the best option to assess these people whether they are in remission now?
I think if I can just
yes,
say
Rupert.
in between, I think the message should be that every IBD patient can get married, but the best time to get married from the social standpoint would be when the disease is in control. Similarly, every IBD patient can have a child, but the best time to plan is when the disease is quiet. And this is particularly for the postgraduates or young gastroenterologists who are watching this show. I think that is the summary of the marriage part before you carry on with.
So, how would you assess these people, a pregnant lady for a disease activity?
So, Tyagi, the best way to assess is clinical. There's very little non-clinical knowledge here. Our title was looking beyond the frequency of stools, but that's the best way to find out whether a patient is clinically in remission or not. Asking the patient, how many stools do you have? Do you have pain? Do you have fever? Do you have joint pains? Or do you have skin involvement? Tells us whether the patient is in clinical remission or not. Secondly, doing simple tests like a CRP and a fecal calprotectin can tell us whether the patient has biochemical remission or not, and that should suffice. Doing an endoscopy repeatedly at this stage is not the answer to assess remission.
So primarily, as Rupa has summarized, this is more of an apprehension of the patients, and it becomes mandatory on our part to actually allay those apprehensions and tell them that there are good managements and they would be well managed provided they are open with each other. And so marriage is no taboo, and neither is bearing children a taboo. But we come back to the same question, and the next question would be, is it safe to have a baby, which was raised initially by Ida. So Dr. Jayanti, is it safe for these people to have babies? Because some of them would have been on certain drugs during their pregnancies and before the pregnancy, etc. So what, as clinicians, we should explore and find out before we give the answer, which obviously is that it's safe to have baby provided you do this, 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 and this. So can we have those provideds? from you.
That this we have already discussed. This is the one which occurs in youngsters, and 25% of them, soon after it is diagnosed, they become pregnant. And we found that about few decades ago, we were some of the physicians were asking them not to get pregnant. They were discouraging them. But nowadays it is not so, because of the advent of, first, on the medical side, we have good drugs to get the disease under remission, under control. And on the other side, as obstetricians, we have great tools to monitor this pregnancy from the fetal point of view. So both ways put together, we know now it is safe to have this pregnancy, safe to get this baby out, unscathed. And also, we have to tell them, very, very important. Now, looking at all these statistics, we know that there are various complications that can occur during pregnancy if the disease is not under control at the time of conception. So if it is not at the time of conception, we have found that the complications like spontaneous abortion and the preterm delivery, intrauterine growth restriction, and fetal death, as well as the venous thromboembolic phenomena, as well as the increased risk for cesarean section, all these things are increasing. Plus also some of the cases where they have a lot of flare-up, they also end up with surgery during pregnancy. So these are all the conditions. Again, they have found that if this condition at the time of conception was well under control, was well in remission, then these complications are almost like the same in the general population. Now, if these things are well under control, the risks are less for the pregnancy, and also how the disease is also going to progress in pregnancy also depends upon the situation at the time of conception. So these are the important factors. So in our country, we have noticed that people have only one idea. If you get pregnancy, you should only take folic acid. All other medicines should be stopped. So you find patients who come to you, the mothers who come to you, having stopped their thyroid medication also. So imagine when they are on these drugs, definitely, invariably, if you are not counseling them before, they will stop this medication and come to you quietly and tell. So it has happened also a number of times that these women will get into more severe form of the disease as they progress. So it is important to tell them that to start with, they have to get it well under control. They should be in remission. And there are some drugs which you can continue to throughout pregnancy. And these are the ones, except that of methotrexate and certain other drugs, which should not be given in pregnancy. Those will be stopped. And they have to be stopped about 3 to 6 months also before conception. And then you take a good high dose of folic acid, and then you go embark upon the pregnancy. So this counseling should be done, and then the adverse effects of pregnancy will also be less. The flare-ups also will be less. So,
and the next fear being, Dr. Yasha, you would be able to answer that better. What are the chances of my baby having the same illness? Yes. Very straightforward question, and I think they need an honest answer from us.
The genetic risk is much more with Crohn's disease as compared to ulcerative colitis. That's one message. Second thing, if we look at the absolute risk of developing in an offspring IBD for Crohn's disease is around 2.7%. And for ulcerative colitis is 1.7%, provided only mother is suffering. If both the parents are suffering from IBD, then the chances become very high, 30%. And if this is extended to the extended family, second generation, third generation, and also with the parents' positivity, then it is much more than 30%. So it depends on who are, that's why the family history, we pediatricians are always in habit of asking the family history, not only of the first generation, second generation, for many other disorders. That becomes important. As far as the safety is, therefore, childbearing is a good thing for mothers who are having IBD. There is no contraindication to that effect. Second thing, I would like to also emphasize on the safety of a baby, which was the question earlier. From pediatrician's point of view, if we have to see that the disease activity remains in remission, then otherwise the chances for low birth weight, prematurity, small part age gestation will be there. And also less of perineal disease and less of surgery during pregnancy or before that also predisposes to these kind of problems. Third thing, for gastroenterologists, I would like to say what are the safe drugs? Few things, just a small line. Don't ever use thalidomide. Don't ever use methotrexate. And very importantly, because they have got the effects, very bad effects. Second thing is if you are using sulfasalazine for some reason for control of IBD, preconceptual counseling becomes important because it results in folic acid deficiency, which results in neural 2 defects in the baby. Therefore, this has to be taken into consideration how corrective measures we are taking for folic acid. If at all, it is mandated to use sulfasalazine. Avoid that. Use 5-AC rather than sulfasalazine. Fourth important thing, which I will tell the mother, that if you are taking anti-TNF biologicals, which will be required during the pregnancy, we will not be able to give the live vaccine to our baby for a period of 6 months. And that will deprive our baby from the rotavirus vaccine, which we cannot use later. But if it is not, you are not using anti-TNF biologicals, then you can freely use the live vaccine in them. So these are the messages for the safety of the child. And I would also add that we see a lot of children with IBD. Every week I see one case. And therefore, we have to take into cognizance the early onset IBD. What do we do with them? Adolescents, they have much more severe disease as compared to adults. Therefore, all this has to be taken into consideration. Other disorders, Dr. Thagi, like celiac disease patients, they come to us, they are adolescents, they become marriageable age. They ask this question, should we marry or we should not marry? These are the common questions with IBD patients may ask us after some time. Thank you very much.
I think I'd just like to ask a question to the panel, and I think I'll take
Yes,
Dr.
sure.
Tyagi's permission for this. Now, everybody says that yes, methotrexate is better avoided, but you see there is so much of unplanned pregnancies happening.
That was the very next question we were going to.
I'm just saying that as a blanket, Ida, what do you think? Should, as a blanket for the the 18 to 45-year age group, we should avoid using methotrexate in women? Because as such, we use more of azathioprine. I mean,
yes.
So
yeah, it's a good question, but I mean, I think the problem is thiopurines is by far my personal choice, and I think it is. But there are times when they can't afford biologics, and even though I don't want to do it, there are some women that I have started methotrexate, or I have continued methotrexate. I had one that was actually on methotrexate from Professor Peter Irving in London, in fact. And I think it's you have to be very, very careful. You have to assess the woman's educational level, I think, to some, or understanding how absolutely devastating it would be if they were to take it. And I think if you really felt, and as you said, a lot of pregnancies are unplanned, that they're not gonna wait their 6 months and then have their baby, right? And then what if it just happens? So I think I agree with you that I wouldn't say no. I definitely wouldn't give a woman of childbearing age methotrexate, because sometimes you have to. They have acute pancreatitis and thiopurines, and you need another option. But I think you would have to assess that person very, very carefully. You probably would have to reiterate many, many times about the dangers of being on methotrexate therapy.
I think Dr. Jayanti wanted to comment.
Yeah, Dr. Jayanti, you wanted to say something?
Yes. we were using this, especially with vesicular moles, methotrexate being given, and we advise these individuals also for ectopic pregnancy, methotrexate being given, and we advise them not to get pregnant. And then, as you said, we have seen these. Some of them come back with pregnancy in within less than 2 months, and some in less than 6 months. And we have found that if about 10 women got pregnant with them within that period, at least 2 of them would land in a miscarriage. So it's just that, as Dr. Ida was telling, that we have to counsel them, and then you let them, tell them what are the pros and cons, what can happen with the methotrexate, because it is one which is antifolic acid is required for the DNA synthesis. So it's in the early phase, we find more of miscarriages happening with this.
Shobna, we've talked about the fact that we have a lot of unplanned.
Teratogenic.
Yes, Dr. Yacha.
6.6% teratogenicity with methotrexate. That is why there's a big no during pregnancy not to use.
You go for abortion.
During.
So that's what I was coming to. Shobna, now you have a lady who, was on several drugs which you would have asked her not to take, or the ones she was taking the right kind of drugs, but she has an unplanned pregnancy. So what drugs are you looking at? What solutions are you looking at? Which drugs are you going to step up? Which drugs are you going to eliminate? So that becomes a major issue, especially in our country where we have unplanned pregnancy. It's not that you've counseled the patient's under your care and been taken all the right drugs in the right dosage. Here is somebody who just comes to you and says, I'm so happy I'm pregnant. And your face drops.
No, so I'm only concerned about 2 drugs, and I think Rupert Leong didn't talk about them. One of them is tofacitinib, which is being used as a good oral biological. It's being increasingly used today. So that's one drug, though it's said that you have to stop it only 1 week before the patient decides to get pregnant. The patient is already on the drug. You've got to screen the patient and maybe do abnormal scans at, I think the gynecologist will give us better ideas of that. The second drug I'm worried about is methotrexate. And with methotrexate, as Dr. Jayanti said, 20% of women will anyway have a miscarriage or will have a termination of pregnancy before it is complete. But I think they should have these anomaly scans going on at, I think they do it at around 12 weeks usually.
Yes, 11 to 13 weeks.
12 weeks is the usual thing. And the patient has to be warned that, look, if there is anything found, we will have to take a tough decision to terminate your pregnancy, even if this is a special child or a precious child.
Yes, but now I come to the slightly more legal issue. Do you offer them abortions?
Not on day one.
No, not on day one. But you have this history. They've been asked to get a scan done at 12 weeks. You know how they are. They get it done at 14 weeks. They don't have an appointment. They come to you at 16 weeks. And so you are stuck.
I will pass this difficult question to the gynecologist.
Yes.
Because this is the gynecologist's domain. And we have, so this is a point to be made where multidisciplinary approach is extremely important.
Yes.
So what I usually do is when a patient is either planning to get pregnant or is already pregnant, I have a multidisciplinary meeting with the patient, the family, and the gynecologist at the same spot. So everybody speaks the same language.
And can I add, whenever we have such a patient, we immediately stop the methotrexate, give them high doses of folic acid. And then we explain everything and take it in writing that these are the terms, these are the complications that can occur, these are the anomalies that can occur. If you are ready to go through that, fine. Otherwise, you go for a termination. So we are offering termination for these individuals. It is their own individual choice there. Even now, even if the NT is abnormal with the Down syndrome, there are some individuals who want to continue the pregnancy.
She's the next question.
It's their wish.
Munira, you wanted to say something? Yes, please.
Yes, I would like to emphasize the importance of joint clinic between gynecologists and IBD specialists. Here in Qatar, alhamdulillah, we have this luxury to have a joint clinic together. And the GI sector with the gynecologist, she attend and screen all our patients from early pregnancy to all through her pregnancy, even after delivery. And the importance of the IBD nurses and the education, emphasizing on those ladies who comes to us without any information or unplanned pregnancy, and their educations, emphasizing the importance of the medication stoppage or starting the medications, being in remission or being an active disease. And the medical legal question regarding the abortion or not, there is a big dilemma, I think, all over the world, whether to abort or to keep, to continue, or self-abortion. Really, there is a medical legal about that even here in Arab countries, we are facing that, and we have the blaming ourselves or blaming our patients. I think we shall put this issue in the medical legal committee that been formed by the corporate itself, rather than taking after the education of the patients, giving them the choices, and the family, the parents, the legal guardians as well. We should bring them all in the spot of the medical legality of this abortion or not. But there is a lot of minds that talks about that, and thank you to bring this important subject up, because it is really making a problem and tension in our areas.
Great. Now, yes.
Regarding the fact that the risk of the child being IBD, public or that fasting mother and father. So the percentage was quite 3%.
Yes. Correct. That's fine.
I think the data is very encouraging for this part of the world. So it is not as high as, in fact, family history. It is not 20% or 10 to 20% as reported. It is as low as 4 to 5%. We've published on this. Direct mother to child or father to child is much lesser. It is usually amongst first cousins or second cousins or within the family. So direct inheritance is very low. I think, how much was it, Partha? It was 2.5%.
Probably more in the extended family. If you take the extended family, there probably could be a statistical bias as well, because you now, when you go on to the third level cousins, you are probably also going into the prevalence of the general population as well. So that's it. Dr. Munira, while you were at that question, a lady is very well settled. She has been on the biologicals and she is well settled. She gets pregnant and she comes to you. And what are the advice now we have for this lady who's well controlled on whatever drugs she are, including biologicals or on other oral drugs? Do you, and she's very keen that she's been stable now for 6 months, 8 months, 9 months. Should she reduce her drugs, and what are the instructions for her, or would you like to step it up? What is the exact thing that you would do for our younger colleagues who face this problem?
Well, I believe that the best outcome for any pregnancy will be in the best remission time. Any patient, she isn't doing well in remission and she is pregnant, I'd rather advise her to continue on her same level of medication and same level of follow-up, and to report any events to the nurse or IBD nurse or to the doctors, her physician directly in her follow-up, or if there is any phone facility to report to her physicians. So she should be monitored closely during her all through pregnancy. So stopping, I'm not with stopping any medication except if it is methotrexate or any teratogenic medications, but any medications will keep her and safe all through her pregnancy with much better favorable outcome, I will keep her with. We don't have a lot of data on the new agents, oral agents, JAK inhibitors, but maybe we could use from the small numbers of studies happened with our colleagues from rheumatology sector and patients with rheumatoid arthritis or psoriasis who used to have the same medications with which we are using. And we look at the data that there is not much unfavorable outcome, as been clearly mentioned by Professor earlier. And I think more of RCT's studies has to be conducted to know more and more about these medications. Other older version of biologics agents, I'd rather to continue with the close monitoring for any further side effect. We know that pregnancy and the hormones of pregnancy may have some protective effect on the babies and the mother during their
Rupa, you have a large experience on infliximab and on adalimumab and others. What are the instructions for ladies with pregnancy and those who've been on this?
So I think
when do you stop it and when do you continue with them till the end of the pregnancy?
I think it's a very good question that you are asking, that what we do. First and foremost, I think I'll ask Dr. Jayanti's permission. I think she will agree. Most patients as mothers, I bring them into the same level because here her opinion matters. So because none of us as doctors can guarantee that your pregnancy is going to be normal. Whether they have IBD, whether they don't have IBD, there can be. So we cannot say strongly that you continue this medicine, nothing will happen. So I can be frank enough to say that statistically what papers we have seen in the world, you can continue the medications, they don't seem to be derogatory, but your obstetrician, I and you will together decide. So regarding biologics, normally there are patients who say I have had such a bad time without biologics and I am stable on biologics, can I continue? The question is not can I discontinue, they ask can I continue? So they are reassured. I tell them that yes, data says that you can continue, but we will perhaps stop a few weeks before your delivery such that the baby does not have high concentration of biologics. Regarding azathioprine, we tell that yes, you can continue. Sometimes the question is different. They come and say, I'm very apprehensive about continuing azathioprine or biologics during pregnancy. At that situation, I say, you are justified, you are the mother. But it is equally important for you to know that if the disease or there is a flare-up during pregnancy, come to us early, because if need be, we can give you steroids, bring it to good control. And I think you have to have the patient on your side, and in modern day medicine, I think that is.
And Rupa, what are the chances of a sudden flare if you stop these?
The chances of a flare, again, it's difficult to predict. You have to go by the non-invasive markers. You get the calprotectin. You keep a close follow-up. Usually for ulcerative colitis, you get the early rumblings. The increased frequency of stools start. And I always feel that statistics in this situation is not important. Every individual you have to tell individually what will happen, even if you say that 30% will have a relapse. And I think
they have 30% relapse when it is well under control, and they have flare-ups 60 to 80% when it's not under control.
Yes.
So with these biologics, it's advised to the first and second trimester, and they're in good remission. You can actually stop in the third trimester to reduce their number, and then you can take the certolizumab, which actually does not cross the pack. It only goes passively and it's not found in the cord blood. So, and if those people who are on some other drug and they have a relapse, you can use the biologics. And if you find that they are, you need to give, then corticosteroids, prednisolone is very safe in pregnancy.
So we come to the postpartum stage, Dr. Yacha.
Yes, sir.
Can I breastfeed my child?
Yes, yes, of course. Breast is best. And number two, you have heard in the first lecture that breast milk has got some safety profile in terms of preventing the development of IBD. This is a big thought right now internationally. So breast is best. Now regarding the drugs, we are giving aminosalicylic acid ASA, no problem. No problem. The levels are so low in the breast milk that they will not exert any biological adverse effect on the baby. Second is corticosteroids, as Dr. Jayanti has said, they are safe to be given to pregnant mothers. And whenever they come, that will get excreted in the breast milk, no problem. Again, the levels are so low they will not exert any effect. Third is the thiopurines. They don't get excreted in the breast milk. That is ASA. Fifth is this anti-TNF, which is biological. Biologicals can be taken avoid in the third trimester, but even if they are required in third trimester, they don't have adverse effect on the baby. The reason is because the breast milk is oral, and orally this TNF-alpha, this anti-TNF will come out, and in the alimentary tract, it doesn't get absorbed in the systemic circulation. Fourth point, if you are using combination of biologicals and thiopurines, the rate of infection slightly increases in the baby. So that's it.
So primarily, he coined the term, the breast is the best for the child, and therefore breast milk should be encouraged. They should be told that the amount that is being secreted is absolutely minimal and is going to have no effect on the child. And I think the reason why we are re-emphasizing all the time is that the aim is remission. The aim is that this patient should lead a normal life like anybody else. There are certain precautions like continue taking your medicine, don't stop them without consultation, and try to be in remission as much as possible, and you're likely to be as healthy a mother delivering as healthy a child as possible if you follow these things. But beyond pregnancy, there are lots of social issues that come into being. We had a wonderful lecture by Jane just prior to all that we had, our panel discussion. And the social issues are so many that I don't know how many of us actually approach these issues in our clinics. So do we actually approach these issues with the mother or with the couple about their sexuality, about sexual dysfunction, about body image, about whether they are voluntarily continuing to be childless, or is it infertility? Because some of them, due to Crohn's, the lady may have tubal dysfunctions or adhesions, etc. That part being aside. So how many of us actually do it, and what is the advice? That it was actually said, we don't want you to be psychologists or psychiatrists, but we want you to open the doors to questioning. So how do we do that, and how many of us do it?
I think that's a good question, and I think we have Malaysia here, Qatar here, India here, and
yes,
I think I see Dr. Pejman there from Iran. I think the social issue, I think we'll just take a quick comment from everyone. What do you think?
Yes,
Dr.
a quick comment on the social and mental health, and not just that, mind you, the health care. If it's the wife who is the diseased, the husband also has a lot of anxiety issues, and vice versa, because the role play changes. What the lady has not done in our society, like going to the bank, now she is doing it. And what the father has been avoiding, going to parent-teacher meeting, they have to do it. So this actually is a conflict of the conventional roles that we are used to be playing. And therefore, I would like a comment on each one of you as to where does the therapy, where does the consultation and counseling lead us to? Does it actually end, or does it begin from where we are ending today? That is discussing social issues with our patients. So Ira, to start with you first, and then Munira, Shobna, Dr. Jayanti, Dr. Yacha.
I absolutely have to confess that it's not something that I proactively ask. I have a busy clinic, and as Professor Andrews was talking about it, I realized I was completely guilty of it as well. I think if I see someone who is very overtly depressed, they don't have eye contact, they look very down, then I do offer, to speak to a psychologist or for psychiatric input, but then I wouldn't proactively ask everyone. I don't know whether it's even wanted in our culture. That's the other problem, because what's also very interesting is that a lot of these patients, the few that I've asked, they say no when I want to refer them to a psychiatrist. They're still taboo. So I think there's so many.
Going to a psychiatrist itself is a taboo, let alone asking these questions.
Yeah.
Dr.
So
Munira,
I don't know how to overcome it.
Any difference of opinion or suggestions here?
Actually, the social problems, it is different from country to country, and the Arab world is totally different than Far East or Western countries, because our ladies are not dominant here, and always they are enclosed to their ideas and to themselves and to their worries. They don't share it. I don't share these fears with my patient in the first session. I need to, first of all, earn their trust. When they trust me as a lady from their society who understand their fears, maybe in the next session, I talk to the patients or the person who's affected. Then I counsel them whether I bring the other spouse if they have concern about that. Here we open the box and we open hearts here. Because if they don't approach the patients in this way, they might lose the trust and not to talk to us, and they come with the uneventful marriage or pregnancies or babies with comorbidity or congenital problems. I think we need to take this issue in a personal way, in a person-to-person, tailoring them to their needs and their problems.
Dr. Bezman, you are in an even more difficult situation of being a male, a gastroenterologist dealing with IBD. That is challenging enough, because there are a lot of basic questions that are taboo in at least several societies to approach.
The one important issue that mentioned correctly is cultural differences during any community, and we should consider cultural differences. And always I trying to have a multidisciplinary approach, and even consulting with the psychologic, or even try to make a friendly relation with my patient, so they can easily express their feelings, their fears. And I'm making a channel to easy communication with my patient via social media, via WhatsApp, via Instagram and Facebook and other social medias. So the relation between physician and patient is so important in this regard, and the patient should understand that his or her best friend is his caregiver, and his physician could be completely trustable.
And lastly, Shobna, you are from a more open society, and yes. Do you suggest that at least in our society in India, where we are a little more open to such discussions, the couple should be counseled together or not?
Absolutely. Absolutely.
So about maybe 4 or 5 years ago, we actually did a study on this to find out whether people with IBD had significant depression or anxiety. And we found that almost 1/3 of them had depression. And that was not related to their disease activity or anything else. The other thing you realize with these patients is that the way you talk to them, if you're accessible to them, many of them, of course, go into depression for various reasons. But if you're accessible to them, open to talk to them, either on a one-to-one basis or with their family, they definitely have a better quality of life.
I have something to say here, and I think this is the right forum to say it. We have conducted a survey, and Dr. Pejman also is a part of the survey of mental health survey across this IBDENC region. We have submitted it for this ECHO for the abstract we just submitted. Interestingly, 2/3 of IBD patients are in some sort of depression.
Yes, absolutely.
Mild to moderate. Severe depression is just 3%. Mild to moderate depression, 2/3. IDA also is a part of the same study. Caregiver burden is equally high.
Yes.
So we talked to the primary caregiver, we did a survey, the Zaret burden interview score was taken, and interestingly enough, again that is crossing 60 to 70% that caregivers are going through a terrible state of life. So I think this is a very important thing, that in this part of the world, mental health, health in IBD patients and caregivers is often ignored, but what we are finding is quite.
And finally, mind you, we are a male dominant society. I've come across not one but hundreds of women who have in private complained to me that they are off medicine or on irregular medicines because the husbands are not getting them the medicines. Therefore, I think wherever possible, at some time or the other during your consultation, you should actually have the couple, so that the family realizes that this is a disease that would, when in remission, would help the whole family. And I think we've had a great discussion, Rupa, and
we have had a lot of questions coming, and I think it's all about breastfeeding and mental health and psychotherapy. We can just go by the names, but we'll answer them individually. We'll send the questions to the panelists. We are just about to reach the finale of the program, and that is so important. I take this opportunity to introduce my dear friend, Dr. Pejman. I'm always stuck at his surname. It is Alavinejad. So Dr. Pejman is here. He is the Professor of Gastroenterology at the Ahvaz Jindishpur University of Medical Sciences at Ahvaz, Iran. Is a pillar from Iran and part of our IBD Emerging Nations Consortium. As for every month, we have a theme country. The country this month is Iran, and here is a short presentation from Dr. Pejman regarding Iran. Let us enjoy that before we say good night.
Dear Chairman Committee, ladies and gentlemen, let me appreciate for giving this opportunity to present our research center, Alimentary Tract Research Center, and Ahvaz Jindishpur University of Medical Sciences. I'm Dr. Pejman Alavinejad, Associate Professor of Gastroenterology.
How did you pronounce
For introduction, I should mention that Iran, as a Middle East country, contains more than 85 million people, and our province, Khuzestan province, located in the southwest of Iran, with more than 6 million people, and is the main center of Iran oil and oil-related industries. Its climate is subtropical, and since almost 100 years ago, after finding of oil, a lot of people all around the country and also other countries immigrated to this region. So we have a mixture of races, mostly Caucasian and Arabs, but also we have some people with descent of Turk, Indian, African, and rest of races. Jindishpur Medical University is one of the most ancient universities in the world, and which established almost more than 17 centuries ago and have been a scientific center in ancient Iran. Our research center, Alimentary Tract Research Center, established in 2011 with 17 active members, and since that time, more than 150 scientific articles have been published with the affiliation of ATRC. In 2012, we started to registration of celiac disease patients, and in 2016, we started the IBD registration, while Iran, it all has also IBD registration, but also in Khuzestan province, we have our own registration of IBD cases. Since 2016, we have registered 786 cases diagnosed as IBD. 50% of them are male with average age of 36 years, range 3 to 76 years, and 83% of them diagnosed as ulcerative colitis, and 50% diagnosed as Crohn's disease. In Ahvaz Imam Hospital, which is a tertiary referral center, we manage our IBD cases, especially complicated cases, and our available medicine, including anti-TNFs, including infliximab and adalimumab, immunomodulators, including azathioprine, NTXMP, CellCept and cyclosporine, kinase inhibitors, including tofacitinib and corticosteroids, and also 5-ASA family. In recent years, we mostly focused to performing multi-centric and multinational research projects with collaboration of other centers, and in this slide you can see some of our published works in collaboration with other centers. And also we have some in-press completed works with participation of other countries. You can see in this slide. And our most recent project is evaluating IBD evaluation and behavior in the last 2 decades, which currently is ongoing. And from this tribune, I would like to invite you to, if you're interested to participate in multinational project, you can join this project because we believe that together we could be more impressive to create a better world for living and creating a better environment. Thank you very much for your patience.
IBD in Iran. I think what we are today is because we are all together. It's always a nice forum for collaboration and cooperation and overall learning the best from each other. I think today's program has become very iconic because we had Dr. Jayanti with us as a gynecologist and obstetrician. We had Dr. Yacha with us, and I think multi-speciality collaboration is again also very important for the management of IBD. I take this opportunity to actually thank the course directors, Dr. G.N. Ramesh, Dr. V. Jayanti, who has been a pillar for production of this nice program month after month. I of course would like to thank Dr. Tyagi for being with us here in Hyderabad at the AIG studios. I also thank Ida. Ida, thank you so much for being there. Ida, Dr. Shobna, your mentors, Dr. Munira, again dear friend, Dr. Peshman, and Dr. Yacha. Thank you everybody for being here with us. Partha and I have really enjoyed the entire discussion and show, and of course Rupert and Jane must have gone to sleep by now. It's 3 a.m. there. So thank you so much for being here. No vote of thanks is enough till we thank our academic partners. And I take this opportunity to thank Janssen, Dr. Reddy's, Microlabs, Takeda for their continued support for this academic feast. Thank you once again, and good night.
Good night. Thank you.
Ida, thank you.
Thank you, everybody.
For you.
Thank you, Rupa. It was a